and it's a real pleasure to get to speak virtually to you guys about how to do capacity assessments and also how cognitive disability fits into that. And, these are topics that, actually we're in the process of creating like a whole year-long fellowship on. So as much as I want to do a super deep dive and go on and on and on, I'll try to keep it closer to a 10,000-foot view, and then, make myself available after and via email for questions. I don't have any disclosures, and my hopes are by the end of this, you guys will, one, have a better understanding of what normal aging looks like in the cognitive, psychiatric, and neurologic domains, because those are the main domains that affect someone's cognitive decision-making capacity. And once we know what normal is, we can better understand what abnormal or pathophysiologic looks like and how that might impact someone's decision-making or executive capacity. We'll learn how to assess it in a global sense. Many of us have a fair amount of familiarity with assessing for medical decision-making. Can my patient consent to this procedure, this intervention? But looking at someone's global capacity, how they manage in their day-to-day life when they're not with us in a clinic or a hospital, is a bit different and more in-depth. And then, of course, geriatrics, we care about giving, person-centered care that focuses on what matters most to them. And so just want to touch on that as well. So what is normal aging? What did we spend our, many of us, our first year in medical school learning? Well, when we age, it's not quite as simple as simply just getting older. I mean, from a chronologic perspective, it absolutely is. We can expect that, when we are created, we will, gestate and do all those wonderful things that turn us from, a cell into a ball of cells into something that has like a tail and looks like it came out of primordial ooze. And suddenly at the end of, 9-ish months, you get this adorable but helpless little thing, an infant that eventually progresses into a, widely toddler and, a bright-eyed child and maybe a sullen teenager, an adult. But what happens after you're an adult? Because certainly you're still an adult when you're 99, but are you the same adult that you were when you turned 18? Probably not. We know that aging is something that is progressive and predictable, but how it happens in any individual's body is a bit unique. That has a lot to do with our genetics, how we take care of ourselves, the lifestyles we lead, and also a little bit of luck sometimes. When you're at the extremes of age, though, genetics matter a lot more than the environment and the lifestyle you lived. There's actually some really cool research that's ongoing. I think I've been seeing it in the AGS forums about longevity studies. So if you aren't signed up for those forum mailings, you should. But if you have really old patients, this is an opportunity to kind of, with their permission, if they want to enroll, to study what allows us to get old and why some people, at 30 seem to be having trouble with their joints, whereas other people at 30 are doing just fine. Why some people have more trouble with their liver or their lungs as they age, but their peer different way, even when a geriatrician is involved. And so while we know that all organ systems are going to be affected by the process of aging, that part doesn't happen in a predictable stepwise fashion. We just know that in totality, a human, if things go, well, we'll assume that getting older is better than the alternative. It kind of is part of our ethos. We know that everything is going to get older, but we don't know when or what is going to feel older first. But we do know one of the predictable things is, just as much as we know that homeostasis is this body's, ability and challenge to stay in this very narrow, steady state of health, and various blood counts and hair lengths, all of those things, they're very closely monitored. That's why, like your eyelashes don't grow as long as your head hair. Things are very, very, very tightly monitored. We breathe out more if we need to balance our pH, or we urinate in a certain way. That's what homeostasis is to maintain this narrow range. But as we get older, we get so-called homeostenotic. Staying in that narrow range is much harder because our physiologic reserve changes and it reduces. And so the body, as we get older, is less able to, bounce back and handle the challenges of achieving homeostasis during periods of physiologic stress. And physiologic stress can seem, relatively speaking, minor. Like, I'm sure many of us, maybe pulled an all-nighter in college, and then 10 years later, we tried to do that as like a resident or a fellow, and we're like, that was not as easy as it was when I was 19. That's normal, and we feel it more. The same as with illnesses. I have a almost 4-year-old and a 5-year-old, and when they get a cold, man, they're good in 24 hours, and I'm like ailing for a few days. And if we are so unlucky as to pass it on to the grandparents, they deal with that cold for like a week or more. Your body's ability to handle physiologic stress without any negative outcome, like delirium or other things, changes. And this makes you more vulnerable. You have a reduced ability to bounce back. And if this reaches kind of a maximal point, we term this frailty. And frailty is when you need to employ like all of your body's resources to stay in homeostasis. There is no wiggle room. Any little thing, the smallest physiologic disruption, can tip you off the precipice. And this is a nice drawing from one of my mentors' up-to-date article, Dr. George Taffet, down here in Houston at Baylor. And this is on the Wikipedia page of, or sorry, not the Wikipedia page, the up-to-date, the doctor Wikipedia page, the up-to-date page for normal aging and some of the physiology and pathophysiology. And you can see this dark gray section is how much physiologic reserve you have, and you can see it shrinking, and eventually it's a little bit dramatic, but like the smallest stressor can tip you off the edge into an adverse outcome, ranging from severe illness, hospitalization, and sometimes death. So we know that all organ systems are going to change, and they're affected not necessarily in a predictable way. Some of them are, but how much it's going to be impacted is not as predictable. And if the normal physiologic changes of ages move into a pathologic area, it can also progress to causing disability of either the physical or the cognitive type. Now, because I have a limited amount of time, and because we're talking mostly about cognitive concerns today, I want to emphasize that having a physical disability is not the same as having cognitive incapacity. So I tell people, if I broke my leg, I'm a bit of a klutz. If I broke my leg, I could still lie in bed, get on my phone, and order groceries through a delivery service. I know how to do it. My brain is still working. I could still make sure food is getting into my house. Lead to cognitive incapacity and thus potentially guardianship if it's very extreme. But cognitive incapacity, which we're going to talk about what capacity means, so hang with me. Cognitive incapacity can lead to guardianship if, the cards and the stars and everything are aligned in such a way that is, although a highly restrictive option, the safest and most practical option. So what we're going to focus on today is first normal aging and then abnormal or pathologic aging in the regards of neurologic, cognitive, and psychiatric domains. So in a normal aging brain, from a neurologic, like a tissue perspective, we expect to see the overall brain volume or size diminish, which can be related to cognitive impairment. We see that in, frontotemporal dementia, Alzheimer's. We see atrophy of certain areas or a global atrophy of the brain. Now, certainly, again, there is normal atrophy of the brain that is relatively minor that does not necessarily cause cognitive impairment. But the kind of things it can cause are when it branches over from normal aging into pathophysiology. So normal aging is when you have reduced cerebral blood flow. If it becomes extreme, it can cause strokes. The amount and quality of the neurons is expected to diminish over time, which can impact learning if it goes too far. Changes in neurotransmitters may play a role in the development of mood disorders. I think in medicine we've come to understand that it's not just, the amount of serotonin in your brain that causes depression. We humans are far more complicated than that, but it can play a factor in it. It takes more effort or neurologic expenditure to do things, and the connections you form in your brain might not be the same, all of which can impact the effort and memory, respectively, to do things. And then in the peripheral nervous system, as well as the central, pain becomes more of a prominent feature, even in relatively healthy aging. Of course, it can go, really, really bad and things can go quite wrong, but more pain is actually part of the expectation. That doesn't mean everyone who gets older has more pain, but it's more common to see. And we do expect it because of a variety of differences, again, which is a much deeper dive than I can do today. From a psychiatric perspective, we know that as you get older, there are increasing life stressors. Even if you have a positivity bias, which is a well-known phenomenon in psychiatric older adulthood, you focus more on the positive things and you see the pleasures of life and you forget and let go of, either intentionally or otherwise, some of the bad stuff that we might dwell on more in our younger and middle adult years. But nevertheless, more people are becoming ill, more people that we love are dying, and ourselves and others might suffer changes in our function, which can impact our mobility, which impacts how we socialize, and it can make us potentially become frail or carry a greater disease burden. Many of us also will experience, for the first time, a fixed income, which can greatly impact socioeconomic status, depending on what one's prior career was, or if their marital status changes either through divorce or death, that can also severely limit income. All of those factors can have a big impact on social isolation and loneliness, which has many of its own associated downstream effects. And these can impact someone's mood. And we know, from research that there are medical conditions that really benefit from just a priori starting a selective serotonin reuptake inhibitor to improve outcomes. And especially social isolation and loneliness is associated with increased mistreatment risks. And the intersection of kind of mistreatment risk and social isolation and loneliness is something that we do quite a lot of research on down in Houston at UT Health. So that's something that I'm in particular very interested in. And this creates kind of a cascading circle effect. When your function change, you can jump in on this circle anywhere, but when your function goes down, it can predispose to, kind of like situational psychiatric illness, which impacts how you view your own life and your own health. And that can, again, worsen your function, worsen your mental health, and so on. And unfortunately, we're not great, both at, well, maybe the geriatricians here are pretty good at it, but a lot of psychiatric illness, specifically depression and anxiety, is missed in older adults, partly because of our screening tools. The Patient Health Questionnaire 9, PHQ-9, although it is a great tool and it's validated in older adults, The geriatric depression scale asks questions that are more kind of mood and emotional based rather than focusing on somatic symptoms, which might already be impacted for myriad reasons in an older adult. They might take medications that impact their sleep and appetite. They may have changes in their energy because of sleep problems that are completely unrelated to a mood disorder. And the GDS, the Geriatric Depression Scale, is great in asking those questions. It focuses, again, a lot less on the somatic symptoms that can be due to other things, especially in an older adult, and again, focuses on those moods. So it's my preferred screening tool. Because I think it really hits at the heart of the matter better than the PHQ-9. But the PHQ-9 is still, in fact, a validated and great tool. So it's better to screen than not screen. It's better to have a conversation, even if it's not perfect. And then from a cognitive perspective, kind of how we think about things, there are changes in processing speed, working memory, attention span, how we problem solve and reason and like learn things. And this can have impacts in our executive function. The good news, and this is something that I think people don't think about enough, is that procedural and semantic memory, so like your memory of how to do things that you've done throughout your life, of speaking and words, and like knowledge, that's actually fairly stable throughout the lifespan. That is not expected to change. You might struggle more to remember like a phone number someone gives you, even if it's chunked, like 713-993, like even if it's like that, it might still be harder to keep those numbers in your working memory. And of course, there's individual differences as well. I always joke that the reason I married my husband, we've been together almost 15 years now, so I guess it worked. But the reason I joke that I married my husband is I, on a lark, just rattled my social security number off to him, like totally joking. And he repeated it back flawlessly and then never forgot it. I went, shoot, now I got to marry the guy. He knows too much. So some people have great working memory. Ironically, my husband's short-term and long-term memory is rather poor, where those are like definitely my strengths, but my working memory is awful. If someone gives me directions in a hallway, turn left, turn right again, I'm just going to walk forward until I meet another person I can ask for the next step of directions. Like, I don't even know why I asked, but everyone's memory is different. An executive function and dysfunction impacts how you can live independently. Again, this idea of capacity. And it's fairly stable up until around 70. And then at around 70, we start to see the decline more pronounced. And so I always appreciate when my patients tell me, yes, I'm having memory problems, but now I'm using some compensatory strategy. I'm putting sticky notes all over the place. Now, that does say, hey, there might be a memory problem, but it tells me that they have the insight to know it, and they also have the judgment to do something about it, which is an important part of capacity, as we'll find. So it's not as simple as just forgetting you don't have capacity. If you make efforts that are effective, especially, it tells me kind of where you are in your thinking about it. I am much more worried about the person who is oblivious to their cognitive changes than the person who is aware and worried. Different kind of things we're dealing with. Okay. And yes, and so that is about compensation. And the good news is our cognitive function is elastic even throughout aging, and we can do things to balance that out. We can make sure that when we're working with older adults, people in geriatric medicine are good at this. We are good at slowing down the pace of our appointments. Even though I'm not talking as slowly as I normally do with my patients, we give more time. We reduce the pressure for completion. We offer support to reduce, some of the stigma of feeling like you can't do it. Like we take some of the stress away without, it's important to not disable someone who is able by over helping. We support them without taking away the task entirely. Because if you don't practice, it's really hard to stay sharp. So we want older adults to do we want anyone, I want my children to do as much as they can for themselves, but in a way that ensures that there is a safety net in case they're having an off day or things are declining in a more permanent sense. But they have the advantage of having wisdom. They have world knowledge, years and years and years of it, that they can draw on. This idea of having a schema or heuristic or a sense of how the world works in certain situations. All of us know that when we go into a restaurant, we stop off at a little table with, a man or a woman behind it, and we say, Hiner, party of 4. Yes, I have a reservation. We know there are certain things, and we go to our table and maybe we take our napkin and we put it in our lap and we open the menu. Like, we know those things are consistent in the vast majority of restaurants. But the very first time I took my children to a restaurant, they had no idea what we were doing at any step. But now, as they've gotten older and we've gotten past, some of the darker days of COVID, my children have gone out more and they understand better about what's going on. And that's normal. We learn our entire life. But what's not normal is to lose function as a result of these expected cognitive, neurologic, and psychiatric changes. Even if you're 95 or greater, it's not normal to lose function. That's always pathophysiologic. So that's an area where people who practice geriatric medicine really need to, get anti-ageism words out there, because people think it's normal to lose function, and it is absolutely not normal. It not being normal doesn't mean we can't support it, but it's definitely not normal. So what is capacity? Capacity in this global sense is the ability of someone to understand a topic, a decision enough to engage in an informed discussion where they can demonstrate that they understand the benefits and the risks of a choice, as well as offering some potential alternatives, if they exist, to complete a self-care task. If they cannot physically complete it themselves, they can coordinate others to perform the steps necessary to complete. So those 2 bullet points, the top one describes decisional capacity. The middle one describes executive capacity. Decisional capacity is when you consider and make a decision. The middle step is when you execute that decision or make it happen. And again, someone else can make it happen for you as long as you can make the decision reasonably on your own. Now, I don't have capacity. It means I'm considering other people to make an informed decision. When someone's making a decision, they might consider short and long-term beliefs, their values, and their goals in making that decision. And that's normal, that's expected. And those things can cause significant changes in decision-making throughout the lifespan. Capacity and the word competency are often used interchangeably, but they are not exactly the same. They're like 2 sides of the same coin. Capacity is more of a medical determination, and competency, or de jure incompetent, as lawyers like to say, is the legal aspect. Can someone be a witness in a reasonable, rational way? Can they participate in a court proceeding? Can they be deposed, give testimony? If they can do that, they might be competent, even if they're incapacitated, because incapacity is a big spectrum, as we'll see. So I included the Texas Estates Code. I understand many of us, if not most of us, are not in Texas right now. But and there's probably 50 definitions of capacity state by state, even though they all get to the same idea. But I'm most familiar, as I practice in Texas, I'm most familiar with the Texas one. And so the Texas Estates Code guides how I do my capacity assessments. That is the bulk of my clinical work, in-person and telemedicine capacity assessments, my interaction with each patient lasting about 2 hours, not including the documentation I do after, which easily adds another several hours. But in Texas, capacity involves an adult's ability or inability, if they are incapacitated, to arrange for the bolded items here, arranging for food, clothing, shelter, health and safety, and finances. And those 5 areas, food, clothing, shelter, health, and finances, are what I consider when I'm doing a capacity assessment. And focusing and also knowing that it is not an exhaustive list, those 6 diagnoses for neurologic stroke and traumatic brain injury, for cognitive dementia and an intellectual and developmental disability or an IDD, and psychiatric schizophrenia and bipolar disorder, 2 of the more severe and debilitating mental health diagnoses out there. Again, not to say that people with those can't do extremely well, but those are probably the top 6 diagnoses I see in my practice. Even though I'm technically a geriatrician, I'm internal medicine trained, so I can take care of anyone who is, adult-like in their physiology. So somewhere between 16 and 18, depending on what my malpractice insurance says. And so I actually still do see a lot of IDD and traumatic brain injury, and also psychiatric illnesses. I'm not a geriatric psychiatrist, but there is significant crossover, especially when dementia is at play, doing that sort out of, is this a neuropsychiatric feature of dementia, or is this a longstanding psychiatric illness that either has become unstable or newly presented? But again, this is not an exhaustive list. So what I want to spend the rest of our time talking about is the nature of disability. So disability, in a large sense, is any bodily or mental condition that causes impairment and that impairment causes difficulty in completing self-care and other activities, or participating in society, either through activities or with other people in the way you want. Disability is extremely common in the United States, affecting about 1 in 4 people. In what kind, the type of disability that affects this 1 in 4, again, includes the spectrum of physical and cognitive. So everything from, low vision to autism to dementia, everything in between, all of that counts. Some disability is visible, some is not. And how disability presents can be very, very diverse, both based on the origin, from where it came from, how long it lasts, is it expected to improve or not? Is it something that is in your DNA? Is it something that happened to you throughout the lifespan? Does it come and go, or is it always there? And the focus is, does it impact your body or your mind? And again, I think as a medical community, we've mostly moved past this, dualistic idea. The body and mind are, one housed in the exact same person, but, there's definite interaction and interplay between them, as we've seen in earlier slides. So it's a bit of a false, split of the idea of body and mind. But for the sake of this presentation, again, I'm mostly speaking about the disabilities that originate in the mind, regardless of the effects that they have on the body. And so, as I was alluding to, the types of disabilities are numerous. And for the sake of this presentation, I'm most interested in talking about individuals who have disabilities with their cognition, with their ability to live independently and to take care of themselves, although these are Certainly not the only types. They do comprise quite a large chunk of the people we're talking about. And there's also significant crossover. So again, it was about 25, 26% of people impacted. And you can see the numbers at the top add up to more than 26%. And that's because oftentimes people, for example, who have issues with cognition may struggle to live independently and do their self-care. So you kind of like double, triple, quadruple dip in some of these categories. And there are certainly, like congenital problems that may cause issues in both hearing and vision and mobility. So it goes both ways. I wanted to talk for a second about stigma. So of course, I think all disability, either historically or more likely currently, still come with some stigma. When we think of a bodily disability, broadly, you can think of it as something that you can perceive in another person. We probably inappropriately, describe certain pediatric patients, as a way of, deciding if they, appear superficially to have a disorder. I've heard it said that, a child looks syndromic. They have features of a disease that manifest on their physical outward body. We can also see amputations. We can see the sequela of disease. We can see, if someone has been exposed perhaps to a fire, we might see manifestations on their skin. We might see the consequences of paralysis or the paralysis itself. But whatever we're seeing, it's visible. And that visibility, although it definitely can cause, feelings of discomfort being around it initially, most of the time, people get used to it. And I think as a society, there's been a lot of movement, although imperfect, but still movement nonetheless, to be more accepting of it and to socially accept and maybe even celebrate it by representing it in the media. I've been honestly happy to see things like vitiligo and use of gait assistive devices in like the advertising in, various like department stores and Target, for example. They're representing more and more body types in their advertisements, which is, again, representation. And when you see it regularly, it normalizes it as like an okay, perfectly normal way of being, perfectly acceptable. Normal is a loaded word in a statistical and population math kind of sense, but it's represented. And so the stigma changes. You see it in, like the Lifetime and the TLC movies, these people accomplishing things. We have, Olympics and, included this, we have prosthetic devices. There are more options for treatments and assistive tools. And that makes the stigma on it less. And the words around it may be more positive. We may describe people with a limb difference or wearing a prosthetic as brave or inspiring. And all of that, that is potentially very true, depending on the individual. And bodily disability also doesn't carry the burden of leading to incapacity and guardianship. But that's different from disabilities in the mind, where there are still huge, huge, huge stigmas, not just because it's more likely to lead to incapacity and guardianship, but it's something that you can't really see necessarily. You might see manifestations of the disease, like someone having a really hard time in public due to being overwhelmed. But it's harder to see overall. And we have a really sordid history across the world of institutionalizing and locking away people with cognitive, neurologic, and psychiatric disabilities, which decreases the positive representation in society and thereby makes it something that we talk about behind closed doors and behind our hands. And that feeds into the stigma. And these are not my words. Crazy, demented, weird. Those are not my words, but these are words that people use. And part of the problem is also they're harder to treat, harder to, and I mean normal in the statistical sense, but harder to normalize here. It's harder to improve someone with dementia, their cognitive function back to a point where it's, not so impactful. We don't have gait devices. We don't have glasses for psychiatric illness, if you will. So what can reduce capacity? We've already touched on briefly the permanent ones: dementia, traumatic brain injury, psychiatric disease, IDD, substance use, especially if chronic, strokes. But in a transient sense, especially like in a hospital, we might see difficulties with medication side effects, the impact of acute substance abuse or chronic illness, a side effect from a medication, or any one of these things or others causing delirium. Delirium is an important thing that we see in the hospital that might temporarily make it so someone does not have capacity to either make a medical decision or take care of themselves. So it can have big impacts. So delirium is an important one. With the more permanent ones, which are the ones that I personally assess, and the one, someone doesn't get a guardianship because they're delirious. Delirium eventually over time will clear and the cognitive status will return, if not to baseline, somewhere near baseline in most cases. But these diagnoses are more permanent. They are things that we can't, fix. But they exist on quite a continuum in terms of the likelihood that capacity may return or even ever just go away. And so someone with mild traumatic brain injury, which is literally a concussion, they might struggle for a while, but they're almost always going to be able to take care of themselves again. Bipolar disorder, very successful, especially if stabilized on medications and or with counseling. Most of them have jobs, have family, they do great. And similarly with people with mild IDD, adults exist at baseline on quite a continuum of ability, even when no disability is at play. So mild reductions in that, there's enough supports and services out there that most people with mild IDD, again, highly successful in life. But as you progress through some of these other diagnoses, especially on the terminal end with severe traumatic brain injury, which is, often people in a vegetative, fully dependent, long-term care kind of situation, people with dementia that we know saving, not frontotemporal, I'm still thinking of the game, vascular dementia, which is a stepwise progression with periods of stability. Most other types of dementia are progressive. We know what it's going to look like, relatively speaking, after certain periods of time. And we also know that dementia does not ever improve. So people with traumatic brain injuries that are severe with dementia, we know that if they are found to lack capacity, it's probably going to be permanent. So I keep saying this word capacity, and I do capacity assessments for a full-time job for the last 6 years. What am I even talking about? So when I'm assessing someone for capacity, and when you in the future may assess someone for their global capacity, how they arrange for themselves in these 5 areas of function: food, clothing, shelter, health, and finances, we want to do a variety of things. It is not enough to just give a SLUMS, a St. Louis University mental status examination, or a MOCA, or some other cognitive test. You need to do more than that. A score on a piece of paper, a screening piece of paper, does not a diagnosis of dementia or incapacity make. You want to examine them. You want to ask additional questions that aren't maybe captured by standard testing instruments. You want to talk to people in their lives. But how do you do those things? So first of all, I like to talk to people. When I have the pleasure and privilege of getting to talk to someone, I don't jump right into giving them a MOCA or a SLUMS. SLUMS is my preferred tool. which is why I really should have nailed that university, but I was going too fast. Slums is my preferred tool. Um, but nobody likes to walk into the doctor's office or get on a telemedicine visit, or have a doctor come into their home. Feel fine. Um, so I like to start off by talking to people. That is way less pressure. It gives me an opportunity to build rapport because in my visits, I see patients once. I do not. I'm like the weird geriatrician who does not have continuity. I get one visit with my patients. So I start by talking to them about their 5 areas of function because these are pretty comfortable topics. These are like not big deal. They don't feel high stakes. If I started a conversation with you talking to you about how you got food, I might ask you, hey, how do you get food? Like, what's your favorite grocery store? How do you get there? What do you eat? What do you like to buy? Do you need help shopping or are you able to do it independently? And if you're not physically doing it, are you maybe making the list of the things you want and delegating that out? Or are you not arranging for food and losing weight? Do you look like your clothes are too big for you? Observe is an important category. If I were to ask any one of you, how do you arrange for your food? You would probably talk for a paragraph. Once you kind of like understood what I was doing, you would give me most of the information you need. You'd say, hey, yeah, I'll answer. I use my phone and I order via Instacart to get food from Aldi and a few items from HEB because they don't sell my husband's favorite ice cream at Aldi. And then it's delivered. My husband does most of the cooking because I'm busy and he's a better chef. I typically don't eat breakfast outside of coffee, but I definitely always have a really good dinner and kind of a light lunch. My weight's been pretty stable. I'll give you all the information with very little prompting because I kind of get the shape, again, that heuristic of why you're asked it. But sometimes what they ask isn't necessarily makes sense. And so I try to confirm what they're saying, try to find the truth, both by information that I work closely with Adult Protective Services in Houston. I'll compare what Adult Protective Services has told me about it. I'll look for, the partner or the child, the adult child behind them when, mom or dad says, oh yeah, I go to the grocery store by myself. Someone in the background's going, that's not true. That's not true. I look for those things. I also look if they say, oh yeah, I eat 3 times a day and I love, having, shrimp souffle and all these fancy meals. And then I open their refrigerator and cockroaches come out and no food is in there. Or the milk is expired, like more than a little. If I see bugs or insects, or if things are too cluttered to even get to the refrigerator, or the power's off, so they definitely should not be storing or eating anything in the from the refrigerator. I look for those incongruencies. So it's all of these areas are mixes of what I ask and how I verify or look for ways to kind of poke holes in what they're saying. And I'm very gentle about it. If they say, oh yeah, no, I've got plenty of food in my refrigerator. And I'll say, well, it doesn't look like you have electricity. Is your electricity on right now? And they'll go, oh no, not at all. Then I know that they're not storing healthy food in their refrigerator. And if they don't get that doesn't make sense, that's concerning. The people who backtrack and go, oh, I guess I did just say I store food in my refrigerator, I'm less worried, still worried, but less worried about them. But when they completely miss their own kind of confabulation, that's very concerning. So again, a mixture of asking and observing in each of these areas. I ask about their clothes. Do they have enough? Where can they wash them? Where would they buy more clothes if they need them? Are there, do they have a warm jacket for winter? It certainly doesn't get as cold as it does in North Dakota, in Texas, but we still have a month or so where they might want a coat. But I look at their coats too. If they're telling me they're washing their clothes and their clothes are dirty, clearly not washed. If I can literally see the pile of clothes in the background unwashed, if they don't have power and they're telling me they're using their own washer and dryer, things like that, that doesn't make sense. I ask about their shelter. Where do they live? I have literally had patients tell me that they're living in their own home, when they've been moved by APS into someone else's home. Or they'll be in a nursing home while I assess them, and they'll tell me they're at their, 101 Smile Drive home address that they've been at for 30 years. Again, incongruencies matter. I care about, is the stuff in their home still working? Do they have a history of utility disconnection? Is it clean? Hoarding and clutter alone does not make incapacity. You can definitely live in a hoarded house and shower and groom and come to work and maintain your utilities and have an otherwise normal life. But hoarding can be a sign of self-neglect or caregiver neglect. And I look for those signs. Again, I look for the incongruencies. Is APS in the background on a telemedicine visit fanning themselves because it's 1,000 degrees in their home because either the AC's broken or it's not turned, they haven't turned it off from the heater setting from the last winter, or is they just don't have power? Are there obvious hazards? Geriatrically inclined folks like home safety evaluations. A lot of those same ideas apply. And when I'm doing an assessment, I literally hit each and every one of these points one way or another, either through directly asking, observing, or talking to collateral sources of information. The physical health area is something that I think we're more familiar with. Basically assessing what is their interaction with the healthcare system and how do they kind of maintain their own body's health. Do they take their own pills? Do they set up a pill box, or does someone have to do that for them? Are the pill bottles in their home, from, we'll say January, but now it's June and it was a 90-day supply, and yet I rattle it and there's still pills in there? For some medications, I will actually pour out and do pill counts just to verify if it feels a little close. But I'll also give them an opportunity to explain themselves. I've definitely had more than my fair share of patients who do have capacity. They will take their new bottle and dump it on top of their old bottle. And I don't advise that because you might never get to the older and older bottom pills. But, there might be an explanation as to why the date doesn't match the most recent fill. So giving them signs, don't assume the worst, but, also come in with a healthy degree of skepticism. Making sure that they're attending to their needs and they've done things to take care of themselves both in the short and long run. Do they have a power of attorney? Have they considered their wishes? Again, plenty of people with capacity have not done a power of attorney and will ultimately die without a power of attorney or an advance directive. So again, these are suggestive, not pathognomonic. And then lastly, I ask about finances. Financial exploitation is a growing problem in older adults. Again, in the AGS forum, or if you were at AGS, not this most recent one, but last year, you might have come to me and my colleagues talk on financial exploitation and financial vulnerability with age. It's a hot topic in geriatrics. And financial vulnerability even before signs of dementia, both from a neurologic perspective and in the way we perceive our own vulnerability. These are areas that are really being studied very intensely right now because of all of the harm happening. Again, I managed to have a full-time job in mistreatment and capacity assessment because it's such a problem. So asking about finances and how they're impacting every other area matters. If they have a financial problem, we're going to see consequences in food and shelter too, for example, because they just can't afford to do it. But I ask them the nitty gritty of, are your bills on auto pay? How do you pay your bills if they're not? Do you write a check? Do you call? Do you go to a store, drop off a check? Is anyone taking your money without permission? Do you know where your bank account is? When does your Social Security come? Is it at the beginning of the month, or are you a middle of a month payment person? Do you have a stipend, such as, from the VA or a pension? And does your home look like you get the money you get? All of those things are important to consider. I also do some degree of a physical examination, but it's a telemedicine examination. Even if I'm in person, it's kind of one of those observation-based ones. I really don't, use my stethoscope, except when I'm on call in the hospital these days. So I am looking at them to see Do they appear to be in distress? Are there signs that they might have a rash or have had a stroke, either hopefully not in the moment, but I'll call 911 on their behalf if that is the case. But do they look like they've lost weight? Do they appear to be acutely psychotic or have altered insight and judgment? Does their thought content not make sense? Are there signs of delirium, an acute onset or fluctuating course of mental status, characterized by inattention and disorganized thinking, or, maybe falling asleep or being, hyperactive during my assessment? Do they seem intoxicated? Again, because a lot of these assessments are happening in people's homes, either with me physically or present via telemedicine. I've watched people drink from open liquor bottles in the middle of my assessment, which definitely reasonably calls into question the outcome of the assessment. And sometimes I will decline to continue because who we are intoxicated is not a fair assessment of capacity. And so we try to find a period where they're sober if we can, but if they're never sober, that might say something about their capacity as well. I also do cognitive testing. Again, the St. Louis University mental status exam. I have them draw clocks because clocks are an excellent test of executive function. Real life is the best test of executive function, which again is why I lead in with those questions. The first part of my assessment, that conversation about 5 areas of function, that is what drives the determination of capacity, not the cognitive testing. The cognitive testing is more confirmatory and supportive than diagnostic. But it's also nice to kind of parse some of it out and go, wow, this is someone whose function really stinks, but they're only showing memory issues. I wonder why there's such an incongruency here. Or, wow, their cognitive testing was incredibly poor, but they're still managing to arrange for their needs. Am I missing something? Or was this just a bad day to test them with a standardized test? I have them do trail making examination, like the fancy connect the dot that doesn't actually turn into anything, unless you treat it like a Rorschach test and try to imagine it looks like something. But trail making tests are correlated with driving ability, as well as ability to task switch between numbers and letters in Part B, and also inhibitory, which is a frontal lobe skill, inhibitory control, stopping at red lights, stopping at stop signs, not merging into other people, things like that. Inhibitory control is tested by them continuing to task switch between numbers and letters on trail making Part B. And scanning speed and processing speed is strongly tested in Part A as well. How quickly can you find and connect the numbers 1 through 25 in counting order without error? And then, of course, my geriatric depression scale, because you do want to rule out confounders. If you're saying, hey, I'm concerned for dementia. I don't diagnose dementia because that is a more comprehensive examination that I can do in someone's home or via telemedicine, because I can't do any labs or imaging to rule out other confounders, but I at least will test for depression and psychosis and things like that. As well as asking questions about, their safety. Are they having suicidal or homicidal thoughts? Is what they're telling me, frankly, delusional and they don't understand? Is it confabulating? Are they hallucinating or appearing to be, kind of attending to things that I can't see, like continuously distracted by something off in the corner, or frankly, talking or interacting with something? What I do, I consider myself an elder mistreatment geriatrician. So I, of course, screen for mistreatment. You don't have to use any fancy tool. It literally can be as simple as, is anyone touching you in a way that you don't want or that hurts you? Is anyone using their words to hurt you, to make you feel bad or scared? Is anyone taking your money or making you sign things without your permission? I recognize those those examples are like double and triple barreled questions. So it's great to slow those down a little bit so they actually answer, no one's taking my money, but they have made me sign things against my permission. You want to make sure you're parsing out and getting the right answers to the right single barreled questions you're asking. I have them spell world backwards or do the days of the week backwards as a screen for delirium, but delirium is definitely also a clinical observation based diagnosis as well. So I'm, watching them intently while I'm talking to them for 2 hours. And then I also have them interpret idiomatic expressions. What does the early bird gets the worm mean? Don't judge a book by its cover. Can you tell me about that? Things like that. And this helps me understand this idea of can they abstract, can they adapt to a novel situation through the process of adaptation? And I always give the joke, I know we're very short on time, but like if I told you guys listening, hey, your power's getting cut off starting at 7 a.m. tomorrow, and you're going to be out of a home for the next 5 days. Good luck. What are you going to do? Besides freaking out internally for a second, you might immediately start to think, okay, I'm going to go crash with my best friend or get a hotel room and, thank God the school year's almost over, or maybe it's over. Maybe I'll just pull my kids for the last couple days. Or actually, I think today is the last day in Houston ISD. Oh, thank God it's summer break. I can just take my kids on a mini vacation or get coverage at work, be sure to pack my medications and my laptop and my suit because I'm interviewing for a new job. You would start to plan. That's the sign of a healthy brain. All of which I just said, but is on this slide as well. People who are incapacitated are going to really struggle with an abstract or a novel hypothetical situation. They are really going to be challenged to pivot and do something out of their normal. And moreover, even if they kind of can come up with an idea at that, again, decisional capacity, they're probably going to fail when it comes time to use executive capacity to enact that plan. And I see that all the time. And that's why these assessments are way more than a superficial conversation. They're really a deep dive that you have to think about. Is what they're doing making sense? Is it matching with their long-term beliefs and values? And then of course I talk to collaterals too. That's a great way to get the truth of the situation, to see what things were like before APS got there, or when they first got there, looking at educational or testing records if there's a concern for IDD, medical records if there's a medical concern, see what medications they're on. Are they on, a benzodiazepine that's impacting their cognition, and that will thus, somewhat invalidate my, and insert confounders into my capacity assessment. And so I take all that, and I've said a lot of this already, but, it's not just the cognitive tests, it's everything taken in totality. Because dementia alone is not incapacity, and a screening test alone does not determine dementia. And then I figure out how to help these people if they are incapacitated. Are things so bad off that if I literally leave without doing anything, they may die or become severely ill? Should I, work with the legal system to encourage their removal to a safe place, either like a personal care home or a nursing home, so they don't die? Real and true. One of the committees I serve on is the Elder Fatality Review Committee, the effort committee. And we see the consequences of what happens when people aren't emergently removed. So it does happen, and it's very scary and sad and very restrictive to pull someone out of their house. But sometimes we must to save their lives. And that's a whole conversation of autonomy versus paternalism, maternalism in medicine. That, again, is a great topic that I'm happy to talk offline. Alternatively, if they're not in a life-threatening situation, do we have time to start the very lengthy months-long process? It takes about 6 months in Texas to get a guardianship or conservatorship. They're the same thing. But it's also complicated. It's also highly restrictive. And does not completely supplant the need for shared decision-making, trauma-informed care, supported decision-making. All those things can and should exist within the realm of guardianship. It should not just be someone coming down and making all the decisions without considering the wishes of someone without incapacity. And so I'll end on this slide. Thank you for my bonus minute or two. But ultimately, the people we care for, I mean, they're people. Like they might be our patient, but they are people who deserve to be treated with all the same empathy and patience that everyone deserves to be treated with. And they aren't just like acting badly or lashing out. These are people that are operating with fewer resources, cognitive resources, and skills, and they feel unsafe and scared and they don't know what to do. And it makes it seem like they're acting out, but really they're just struggling. And so it's not their personality, it's like a whole lot more of everything that's happening around them and to them. So one, being conscientious on our own of the fundamental misattribution error, but two, giving people the benefit of the doubt and knowing, the biases that we carry in. All of us carry them in. We are all imperfect, and that's okay. We work against that. We try to be better by having empathy and patience, by building this rapport and trust, so we can have an opportunity to help people, so they know that we're doing this from a place of kindness, not a place of, totalitarianism to run their lives. We focus on their ability, not their disability. We try to figure out what they can successfully still do. We try to grow the skills that they have whenever we can. Even if it's a progressive disease, what can we do and how can we help them do more should be the mindset, because ultimately you cannot have disability without first having ability. And that should be the focus of everything we do for patients like this.